Okay, so if you're ready, so I would request you guys to go to Slido and then connect because that will be much easier. So this is the first one. Okay. So this is the now this again, this is very common in UK exam, and I used to get confused. This is something I see in clinical practice as well, and it can be very challenging. And I remember in the UK exam, especially in the theory in part one or part two, you do get this in various forms, and you have to be very accurate on this one. You need to have some basic idea. So again, because it's a time-based exam, I think we'll go quickly. I won't give you too much of time. Okay. So this was the genital appearance. Sorry, I'm sorry about that. We just went to. This is the genital appearance of a 2-year-old Caucasian girl, obviously very young child, who was referred to the clinic because of parental concerns over pubic hair. Okay. So you can see obvious what's there on the screen. I think that's, you know, and as I said, I think the chat is disabled, but you can use the question answer box. There is a question answer box which you can use for if you want to type or anything. Okay, that is available. So now, how would you investigate this child? So please scan. I've given the scan. You can scan this or go to slido.com. I'm giving you 2-3 minutes for that. And hashtag 2568527. Okay, once you've done that, can you just give me a message? Just from the chat or Q&A or whatever. So Shashwati, Tanushri, Krishnakant, Pooja. Okay. Uh, oh, that's right. Oh, done. Very good. So now, please, can you do the Slido? Join at Slido. Have you all done? Join the Slido. Just say yes, then I will know. That will just make things much more interesting. Take it from me. And it's not. And if you're struggling, please, yeah, because Shashwati have joined. Very good. Very good. Because it will, that will, because in the exam, the time is limited and I want to see how you commit yourself. Okay, if you join, chat is working. Yeah, chat is working somehow. I don't know why, but it seems to be working today. Every day we struggle. Okay, thanks for using the chat. Now see the choices. Karyotype testing, ultrasound of pelvis, thyroid function test, blood for FSH, LH, and estrogen levels, and blood for 17-hydroxyprogesterone level. So please, you know, give the answer. Give the answer. Go to slido.com. Put hashtag 2568527. Okay, have you done that? It's not big thing. It's not a rocket science, and it is very commonly used in other meetings. So please go there. And let's see. So 5 people have answered. Brilliant. So blood for 17-hydroxyprogesterone, and most people have it. So if anyone is left, you can do that. But great, you're using it, and you can see how useful it is. No, because you can see where you are, where are you getting raw. But yeah, chat is working today, which is great. But I'm also very happy with Slido. You guys have finally started using Slido. Because it was earlier only Deepa was using it. So karyotyping, ultrasound, blood, but most of people have gone for blood, 17-hydroxy progesterone. Okay. So obviously, what it says, there are a few tests you have to do. So it's not just one. Okay, 1, 2, 3, 4, 5, as you can see. Yeah. Most you have to do all the tests really. It is actually, I don't know if I give the choice, actually multiple choice answers. So basically, what's happening is, it's first of all, what is precocious puberty? Precocious puberty in girls is before the age of 8. This is what comes up in the exams again. And in the boys, it is 9 years old. Okay, that is cutoff age is 9. And it is central and peripheral. These are the two main things which you need to remember. I'm going very quickly. Obviously, you have to study in more detail. And there's obviously central is mainly idiopathic. In boys, it is mainly idiopathic, but in females, it is more suspicious. There are usually some causes. So mainly exposure to androgens or estrogens. So whether they have taken some medicines, and staging of secondary sexual characters have to be done. Now, obviously, one of the important tests, apart from FSH, LH, and estrogen, testosterone, we forget is thyroid, and that's why it came in the, I gave the question, because TSH people forget to answer. Thyroid is also important. So you are checking for growth as well. Apart from sex hormones, LH, FSH, estrogen. And obviously, when you're checking for growth, you check for bone age as well, skeletal maturity assessment, because is the growth, and you're checking for precocious puberty. What does that mean? Development of secondary sexual characters before your normal time. So that means obviously you have to say whether it is syncing with the what do you call the child's age. So what is the bone age of the child? Is it matching with the hormonal staging? So that's why the bone age is done, and you do the thyroid, obviously the LHFSH to see the sexual, the hormones, how they're working. CT and MRI, because sometimes the bone age might be delayed or sometimes it is, advanced. CT and MRI, because where there is sort of a central precocious puberty, especially in females, I don't think we hesitate to put the CT and MRI scan. You wouldn't hesitate because, the central tumor, depending on the hormonal findings, you might have to rule out the central cause. But obviously, if there is a masculinizing effect or genital ambiguity, then you have to rule out I think which everyone did very well, the karyotyping along with 17-hydroxyposition. Excellent. Everyone did 17-hydroxyposition. So that you have to do that. Because in females, it's virilizing effect of the tumor, isn't it? It's called virilizing effect. So male effect. So that is due to androgenital syndrome. And obviously, you have to investigate. This is given in short, adrenal, ovarian, cerebral, hepatic tumors, because that's why they said in females, they are very suspicious. It can be any of these tumors. And obviously, you refer to a pediatric endocrinologist. So I hope this was useful because these are very quick revision of very important topics which keep coming up in the exam. Okay, right? So we go to the next one then. All right. So this is obviously this is just again I found it very useful. This chart, central precocious, as you know, it is usually hamartoma tumors, arachnoid cysts, meningomyelitis. Idiopathic is common in male. Hypothalamic. So these are the main ones in tumors in central ones, idiopathic. Peripheral is very important. And there are some syndromes as well. McCune-Albright syndrome. Hypothyroidism itself causes peripheral precautions, which I forget. And I forgot to mention because you have to take a history. Suppose you get a case in the, in the long case, in the clinicals. Exogenous steroids, oral, I forgot to mention that. Obviously, OCP, anabolic steroids, and facial creams are important. The most important, which you always remember, is adrenal causes. Adrenal tumors, very, very common. Comparatively, congenital adrenal hyperplasia, Cushing. These are absolutely vital, as you know that. But obviously, ovarian causes as well, which sometimes we seem to forget. Granulosa cell tumor, because these are estrogen secreting tumors. Androgen secreting tumors are sertoli Leydig cell tumor, adenoblastoma. So I think these are important ones. And incomplete precocious puberty is basically you're only having one particular thing, so premature thelarchy or premature adnarchy. I thought this was excellent. So again, this month you have to have a good idea about the staging. Okay, there's no reason why you should not know this. The main thing to know, just have an idea. Remember that the testicular volume is less than 3 milliliters in males. And, it starts with that. And then it changes scrotal skin and structure. And then the size keeps going up. There are different sizes. And obviously there is a, measurement. You have an instrument which helps you to measure the size of the testes. And further enlargement, glans penis, adult stage inside, no pubic hair, sparse pubic hair, the breast development as well, Again, very simple, adrenal tumors, anatomical, functional, it's like congenital adrenal hyperplasia. Exogenous is separate, gonadal means gonadal dependent, gonadal independent. Okay. So again, without going into too much detail, have a look. This one again, I found very useful, this particular one. So criteria of precocious is boys less than 9 years, girls less than 8 years, central high estradiol. How would you know it is central precocious puberty? The criteria will be there will be high estradiol or testosterone, and LH-TFS ratio should be less than 1 or greater than 1. So that one would be helpful. Neurogenic central precocious puberty. So I just can't remember what is CPP. Basically, I guess it's saying central precocious puberty is now, and obviously abnormal CT scan. Idiopathic again is normal. You won't get anything. The CT scan will be normal. Peripheral precocious puberty. Again, the LH and FSH central was LH to FSH ratio is greater than 1. The LH and FSH here, LH and FSH ratio is less than 1. Okay, so this is one you have to know about. premature adenarche, pubarche, no other secondary sexual factors, and DHEA is elevated, dehydroendoepiandrosterone. And obviously the LH and FSH, they are not increased. So it's worth going through this in detail. I hope you find this interesting. Yeah. Okay. So I hope that was good. Yeah, I hope that was good. So next one. 5-month-old infant referred to clinic with a history of skin rash, persistent cough. Examination, he was found to be underweight with exfoliative rashes in his groin and over the scalp. He had a chest X-ray. I'm reading again. 5-month-old infant referred to the clinic with a history of rash, persistent cough. Examination, he was underweight, exfoliative rashes in his groin and over the scalp. He had a chest X-ray. So you can see some findings in the X-ray, and you can see the scalp as well. You can see the scalp. Okay. So with the 1, 2, 3, without wasting much time, I think we'll just go. So what are the most likely diagnoses? Eczema, zinc deficiency, thrush, letter C disease, cystic fibrosis. So again, the exam, get ready for the exam. That's the reason we are doing this, because you have to do very, very quick. You know, in the exam, you won't have much time. A lot of people I know in the theory, they are not able to complete the exam, finish the paper. They take so long. So I will click and let's see what the answer is. Okay, if you have done it, so only 2 people have answered. Please answer. So only 2. I think there are 3 more people who should be answering. Please answer. Please commit now. If you wait, then you're just, just even if you get it wrong, just in the exam, there'll be a lot of time pressure. So don't waste time. Just do it. But if it's wrong, then okay, you're learning. No, this is not the final exam. Just see what it is. Because in the exam, you won't get that much pressure. So the reason we are doing this is to get you used to the time pressure. So 3 people. What about 2 others? They're abstaining from voting. Not decided. Carry on. So we got the reason now. So those who've not done it, it is your loss really. So obviously zinc deficiency is one of the things, but let us see. Eczema, thrush, cystic fibrosis. Now with zinc deficiency, will you get so many other problems? That's the thing. Now what investigations would you perform? So please again, go for it. Go for it. We've got some of the hints, as I said. So the features they said was not only rash, there are lung changes, scalp changes. So do you get everything in zinc deficiency, or is something else going on there? And what could it be? Is it cystic fibrosis? Is it lettuce? If you remember what is that disease, what they've named, yeah, the 2 other diseases. I can't pronounce it very well, but you saw the names. Lettuce UE. So only 2 people have answered. Please answer. Please take a minute. I won't wait too long, because in the exam, if you're not answering now, you take it that in the exam, you're not able to answer the question. Then you have lost it. See, in the exam, you don't get negative marking. So that's why I'm telling just answer, whatever. Because what you think, in the exam, you think I'll answer later on, and you will have missed it, and you would have lost. There's no negative marking, okay? So 4 people have done, only 1 person is still abstaining. So CT scan of the lung, skin gap C, sweat test, zinc levels, skin prick test. Okay. So now let us see what's going on. So this was letter C disease, following specialist referral to pediatric hematologist and skin biopsy. The diagnosis, see, this is one of those questions which you either know or you don't know. Okay. So obviously it was not zinc, because zinc, they don't have only so many features. They would not give you a picture of X-ray or a scalp in the case of zinc deficiency. So it is letter C. And his child looks class 1 histiocytosis, Langerhans histolysis, which has also got the histiocytosis actually 3 types: eosinophilic granuloma and Hand-Schuller-Christian disease. Now they are all characterized by characteristic intracytoplasmic granules in Langerhans cells. I didn't get a chance to get the picture, but hopefully I should have. You have seen what a Langerhans cell looks like. Okay, so this is the basic thing. Let us read. Now, what else? It has got poor prognosis and occurs in infancy. Skin, bone, liver, spleen, lymph nodes, all are involved. any organ basically, and causes failure to thrive. Characteristic seborrheic type of skin rash and infiltration of the lungs will cause progressive tachypnea and interstitial X-ray. So the chances are there's not much of good treatment, and basically what happens is you do use wind blasting. Okay, zinc and latest sweets. Okay, Deepa, you said that. That's good. So let's see what else I've said. So 4, 5, 3, 1, 2, 3, 4. Basically, so what is 4, 5, 3? What is 1, 2, 3, 4? Let's see. What was 4, 5, 3? So obviously, letter C was the most likely diagnosis. We know that. And obviously, as far as the so these were the skin biopsy was the test. Yeah, skin lung is okay, and biopsy would also skin biopsy was the test we were doing actually. Okay, and zinc level, okay, you can do the rule out. If you have multiple choices, skin biopsy one of the things. Zinc level as a differential diagnosis. CT lung scan you can do that because the lung filtrates. Okay. 1, 2, 3, 4. But again, it's a question of differential diagnosis and which one comes first, most likely. So obviously literacy disease, then zinc, then others. Okay. So see you which way you are, what is most likely. All right. Okay. So next let's go to the, so let us see a few more things. I put slides. So basically less than 2 years of age, so that's one of the things, remember it. And in children, other children less than 1 year of age. So basically, usually less than 2 to 1 years, and 1 to 2 millimeter pink colored lesions, papules, pustules, vesicles in the scalp, flexural areas of the neck, axilla, perineum, and on the trunk. They can become tender, scales, and crust with secondary petechignation. Development of petechiae and purpura also common. And as I said, it can happen in all over the skin regions, all the liver, lung, lymph node, bone involvement. And there may be hemopoietic system involvement. So thrombocytopenia and anemia can also occur. So that is what it is. This is one of the pictures where you can see the scalp alopecia, you can see the features and infiltration in the skin and lymph nodes rapidly fatal. It can be rapidly fatal. So not a very good disease. So next question, very quickly, without wasting much time. 1-month-old baby girl born with right-sided periauricular skin tags noted to have abnormality of the eye. The ophthalmologist diagnoses this as an epibulbar dermoid. So the question to you basically is, small baby who's having a periauricular skin tag, and it says very clearly this is epibulbar dermoid. So either you know what it is or you don't know. And for the MRCPCH exam, periauricular skin tag is a common thing which keeps coming up in the exam. You can't miss it really. Okay, there is no excuse. So let's see what your answers are. Now, what are the abnormalities may be associated with the underlying syndrome? So the choices are, you can have multiple choices: unilateral facial hyperplasia, hemivertebrae, cardiac abnormalities, severe learning difficulties, imperfect ANS. So again, I'll just wait for a few minutes. I'll count mentally for maybe 5 to 10 seconds, and you need to take a decision. As I said, the good thing in this exam is there is no negative marking, and obviously you need to, you don't want to lose precious marks. You need to know which one is the right one. There may be more than one answer here. So 4 people have answered good. So that shows that you're prompt to take a decision. So let's see what you're getting. So unilateral facial hyperplasia, hemivertebrae, cardiac anomalies, learning difficulties. Okay, let's see what's going on. So this is obviously 1, 2, 3, 5, golden horse syndrome. Golden horse syndrome, that's what it's called. So what is golden horse syndrome? Presence of preauricular skin tags, it causes about 1% of all infants are born. Okay. So it is a golden horse syndrome in a baby girl. True incidence is unknown. Basically, it affects the first and second branchial arc while developing. The innate is sporadic, and they might have cervical and thoracic vertebral anomalies, underdeveloped jaw with both external and middle ear abnormalities. Now, one of the things which helps characterize the diagnosis, particularly the epibulbar dermoid. I should have highlighted that. That is very important because in the scar, as you know, in different, there are a lot of, for the MRCPCH, there are a lot of syndromes which have, like in Wilson's disease, you get a particular finding in the eye, isn't it? Then in aniridia is found in another condition. So cataract is found in another condition. So the eye itself, the different eye conditions which are there in different diseases. Epibulbar dermoid is characteristic of golden hours. Okay. So, as I said, Wilson disease, you have the K-Fisher ring, isn't it? Then you have aniridia in some other condition of the eye, if you remember. So, you should have very clear idea. This is a benign fibrous tumor found at the edge of the cornea. And obviously, they need to be followed by ophthalmologists. Cardiac and renal are also found. So, just you need to also have a rough idea where else do you get the preauricular skin tag. So, just remember Beckwith-Wedman syndrome because it's very common for the MRCPCH exam. Now, there are other syndromes called Branco-Otto-Renal syndrome. I never heard of it. Some of chromosomal deletion syndrome. Basically, for all practical purposes, any child, newborn who's born with the preauricular abnormalities, you screen by ultrasound for renal anomalies. Okay? You screen by ultrasound for renal anomalies. That's what you need to remember. Okay? So, I hope that's good. And because these are typical common questions appearing in the exam. So, again, that's I thought a few features. Now it's called OAV syndrome as well. Oculo, so eye, auricular, ear, vertebral. Oculo, auricular, vertebral syndrome, OAV. Rare congenital defect caused by, characterized by incomplete development of ear, nose, soft palate, lip, and mandible on one side. So if you see one side of the face is not developed there. And you get limbal dermoids, preauricular skin tags, strabismus, deafness, scoliosis. Ocular abnormal epibulbar dermoid. So remember that is coming up. It also get microophthalmia. So microophthalmia and coloboma. So these are there. But the main one is this epibulbar dermoid characters. ENT, preauricular trachea, hearing loss, and something micrographia. Now, most of the features are unilateral in 85% of the case. Ocular features, especially bilateral dermoids, are seen in 60% of the cases. Okay. I think we've gone through this and I'll just go to the next one. So this is interesting as well. 3-year-old girl was referred with a 6-month history of recurrent soreness around the anus, bleeding and mucus. And between the mucus episodes, she was quite well. Have a look and don't take too long because this comes up in the exam. I definitely found it in coming in numerous exams. Okay, have a good look. Now, what is the diagnosis? It should not take more than 5 seconds. Keeps coming up in the exam. So you need, like the eye symptoms, you should also be used to X-rays. You should also be used to perianal lesions because there are different perianal lesions present in different ways in the Royal College exams. Pretty good. I think that answers, I think that's pretty good actually. 5 people have answered. So it is perianal dermatitis. It is group A hemolytic streptococcal infection. And it might be misdiagnosed as thrush. And it is confused with, sometimes people infuse with chronic inflammatory bowel disease, especially in the UK, or ulcerative colitis or Crohn's disease, or sometimes with child abuse, which is not. And you do a swab and then you get a definitive diagnosis within 24 hours. Okay. So that is one good thing. And let's put it here. And systemic anti. So the treatment is important. So you have to give, so it's not local treatment. It's basically systemic antibiotics. You have to give oral amoxicillin. Okay. And clindamycin is also another choice. So you might get in the exam these two, what is the treatment for this? And, very tempting to think that you'll give some local antibiotics and it will get resolved. No, it doesn't. You have to give oral antibiotics and or either amoxicillin first choice or clindamycin, and it's quite effective. So very good. I think that was a good one. We'll just move on to the next one. So this is a 2.5-year-old boy who was brought to his nursery by his nursery teacher to A&E because of an unexplained scar below the right nipple. No other abnormality was found. Again, be careful of these ones. I guess you are seeing what, the teacher, why the teacher brought to A&E because, she was worried about something. The Royal College exams, anything to do with NAI and all that stuff, or, around that, the markings are usually higher. So you need to have an idea what it could be. So let's move to, please mute yourselves. I think someone is not muted yourself. Please, everyone, please mute yourself. Okay, I can hear some background noise. All right. So I will straight away go to the next one, the answer. The choices are, as I said, insect bite, ringworm, cigarette burn, eczema, psoriasis. Okay. So I'll count till 10. You shouldn't take to, again, in these cases, you either know and you don't know. Don't waste too much time. Whatever is your first impression, go for it. Okay, some people are still hesitating to, I don't know why you're hesitating. Just put your answer. It doesn't matter because it's better some action taken rather than no action taken at all. Even if you get wrong, at least you know where your instinct was going. Because if you don't give an answer now, no, you will, and when the answer comes, you will think, oh, I knew I would have actually given that answer, whereas actually you would not have. So, you will get a false satisfaction. Oh, that is what I would have put as the answer. When you see the right answer, it's so easy. But what I want to do before the answer comes, commit yourself and see, are you actually getting it right or not? Otherwise, very easy to think afterwards that, oh, that is what I would have put anyway. And that will give you a false sense of confidence. Whereas if you put a wrong answer, you commit yourself, then you will know, no, this is my knowledge. So cigarette burn, insect bite. Okay. It was insect bite. Okay. It was insect bite. Obviously, the teacher brought the child to the A&E because she was worrying about NAI. She brought to straight to A&E. Maybe there were some concerns and all that. It might have been. But how do you think? Cigarette burns are more likely to be inflicted over the outer exposed art. So there are particular areas where it is more common, like forearm, the back, face, and hands. These are where that is given. And often in bruise all approximately of same size. So you will find a cluster of the same thing happening. In regard to the diameter of a lighted cigarette end, with the same shaped edge to the scar. However, they may be found anywhere, obviously, when these are the common areas where they're found, but they can be found anywhere, including the genitals. And single burns is with no significant pasture, that can be difficult. But basically, this was an insect bite actually. Okay. Cigarette burns are a bit more difficult. They're more common in forearm, back, face. So the ones I have seen in the exam usually is on the face, or sometimes in the bottom or in the arm, forearm. So those are the ones which are more common. Okay. So just to get used to it. So let's move to the next one. Now, this is an interesting one as well. Very interesting one. So, 1 month-old baby girl was referred to the clinic by the health visitor because of a lump in the left groin. Okay. So, what could be happening here? Have a good look. It's left groin, quite prominent lump. Okay. So, what is the possible diagnosis? Or what are the possible diagnoses? So, which are the most possible ones? Is it a hernia? Is it ectopic ovary? Is it ectopic testes? Is it lymphadenitis or is it hydrocele? What do you think is going on here? Again, no need to take lots of time. Just commit to an answer. Okay, so very quick answer. That's good. Let's see. So inguinal hernia is common and hydrocele of the canal of back. Okay. Then I will come to the answer next. So what is the investigation you'd like to do to establish the diagnosis? I think this is fairly straightforward question. Don't take too much time. So that's very quick. 5 people have answered. USG is the commonest step, and I'm glad that someone has mentioned karyotyping. So 1, 2, 3, 5, and 2. That was answer. Ectopic ovary is the one they're thinking about. Okay. So if you look, sorry, I just looking back. So inguinal hernia, ectopic ovary, ectopic testis, and hydrocele of Karen, not lymphadenitis. Obviously not lymphadenitis. So those were the choices, and those were the answers. And obviously, the answer to this was also the answer to the second
So
one
what
was
was the answer to the first?
sorry, ultrasound is the one they're answering here mainly. So
Are
USG is
these
the one.
questions with multiple choices? Four choices.
Yes, yes. So you can give multiple choices. Some of them you can give the most possible. So you will see what it says, what investigations.
But is it not mentioned, sir, how many answers you are expecting?
In this one, see, this is not, I have not given an exact question exam form. In the exam, it will be very clear cut. In the
Yeah.
exam, there will be very 2 or 3. It will be very clear cut. Don't worry. Okay. Here, obviously, I have not mentioned that. But here, more or less, you need to have which is the most possible one. Okay. In the exam, there will be no doubt about how many answers you should give. It will be very clearly mentioned. Okay? So anyway, so if we go through this one, the presence of mass. So when you're seeing the questions, see very carefully what is written. It will say either what is the most possible diagnosis. So it will say very clearly whether they're wanting one diagnosis or whether saying possible investigations or what is the most relevant diagnosis or what is the first investigation you will do. So in the exam, see what is the exact thing they're asking or what is the commonest or what is the most characteristic lesion in this condition. That is obviously one answer. The characteristic is something, commonest lesion found in this condition is different. Okay. So you need to be used to the MCQs. You have to be, don't worry too much here because here, some of them are like multiples. But get used to that, get used to the thing. So anyway, so ectopic, because this is more because it's a female child and you can read it, you'll get the answer anyway. The presence of a mass in the labia, but in the exam also, if you've got multiple, you get marks. So you get, so if it's not, so there are differential diagnoses, suppose. So there are 2, 3 answers. You will get the first one, the maximum marks. The second one is differential diagnosis, you will get some marks. It's not that you will not get any marks. And the third differential diagnosis, you will get some marks. Okay, so that's how they mark you in the exam. It's not all or none. But obviously, it should be in the differential diagnosis. Then you will get some marks. So presence of a mass in the labia should prompt concerns about whether it's an ectopic gonad. So basically, the first thing, rather than hernia, especially in a mass in the labia, you should think about it's a gonad, and that's why this question is so important, rather than hernia. So it could be ovarian testis, and somehow it said the infants could have an intersex problem. So more than 50% of females with testicular feminization syndromes have hernias. So USG of the hip and sex stereotype. So USG of hip lump, that's very straightforward. But sex stereotype is where you get all the extra marks because, as you know, presence of mass in labia, there is a chance of familial testicular feminization. So stereotype is important. And obviously, again, this is again further down the list. So this is not wrong. Cyst on ultrasound examination would suggest a hydrocele. Now, treatment, obviously, it can be treated by needle aspiration, but pediatric surgical referral is that is basically the most important thing. Would not do needle aspiration. That is not very important. So this is the thing. Let's go to the next one. Again, it's about rash. This infant developed intermittent diarrhea and rash over his fingers, face, and perianal area. Okay, you had a good look. And then we'll move on. Here's very straightforward comparatively. So it says very clearly, I'll just go back again. The clues is there in the answer, in the question only. Intermittent diarrhea, rash over fingers, face, and perianal area. And diarrhea. So what could it be? Eczema herpeticum, candidiasis, acrodermatitis, seborrheic dermatitis, xeroderma, impetigo, ectodermal. Anything going on here? Not many people answering. Okay, some people hesitating. Anyway, I'll move on. Okay, good. What is the treatment? Answer it is not as difficult question as it looks like. We have answered this lot several times in the past. This question we have come in various forms. So please go for it. See, if you're not, again, if you're not committing to an answer, you're just delaying, you're not in the exam, you'll make the same mistake. Get into the habit of committing yourself. Make a quick decision based on why or why it is, or what is the most likely, and commit yourself. Because in the exam, you won't get all the time in the world. Okay? So you got IV acyclovir, hydrocortisone, zinc, oral prednisolone, emulsifying cream, sorbitol, amyloglobulin. So this is the treatment which it is multiple, but that doesn't mean you mask everything and say, not like that. At least you can put the most likely answers. Okay. So zinc supplement is the most, the common one. Someone has put acyclovir, emulsifying cream. Obviously, if you're such a dry and crusted, that is common sense. You would use a emulsifying. So it is acrodermatitis enteropathica. It is basically an autosomal recessive condition with defect in zinc absorption. So this is two types actually. One is just zinc deficiency where the diet is less, not having enough zinc in the diet. But there's another condition which is actually inherited, autosomal recessive, where it is defect in zinc absorption. First week, it appears in first few weeks of life, and if the child is on bottle milk or when it's weaned off, erythematous and crusted, sometimes vesicular and pustular. Lesions appear in the knees and around the nose, mouth, eyes. So basically more around the orifices. So around the eyes, nose, mouth, ears, and also you get soriform rash around the knees and elbows. That is why it gets confusing really. Okay. Secondary bacterial fungal infection is also very common, and lowered serum zinc is found, and treatment consists of giving oral zinc. Now this is basically a lifelong treatment. I think that is what you need to be aware about. Okay. It's a lifelong treatment. All right. So I hope that was useful. I think this keeps coming up in exam, as you know, various types. Not a new thing. Anyway, so let's move on. So again, let me just get this out of the way. Yeah. So if you see here, it is an eczematous condition related to distinct deficiency. So as I said, there are two types: congenital or, because I was aware only of the dietary deficiency, but there is congenital or acquired, which is secondary to prematurity or dietary. The congenital is because of, as it says, due to mutation in transmembrane zinc uptake, autosomal recessive, because that's what might come up. So you get red inflamed patches of dry skin around orifices, which I just mentioned, mouth, eyes, and around the anus. The perianal you must have seen, skin on elbows, knees, hands, and feet. So this will be prepared that in exam you will get a lot of pictures like this. And the differential diagnosis is atopic dermatitis. So suppose the choice was atopic dermatitis, and then given the choice, you would have got some marks. Patches evolve into crusted, blistered, pus-filled lesions, sharp demarcation between affected normal skin. The nails become paranoid, inflamed, and there may nail ridging. So zinc deficiency can cause nail ridging. Mental retardation, diffuse hair loss on the scalp, eyebrows, and the eyelashes. So you will get pictures of the scalp as well, and eyes. And secondary infection, candida, staph, red glossy tongue, and nail ulcers with diarrhea, impaired wound healing. So treatment is with zinc supplement, as you saw it for life. So what is the triad of this condition, acromegaly, dermatitis, enteropathica? So remember, it is acro means alopecia, dermatitis skin, enteropathic means diarrhea. So just remember ADE. Acne dermatitis enteropathy, ADE. Alopecia, so they will show a picture of the scalp, dermatitis, the skin condition, and diarrhea. Okay, so that's the one. And you can see again around the scalp, perianal area, around the orifice. So that's the classic way. Now, let's have a look at this one. So this is an 11-month-old baby boy who was brought to A&E with a one-day history of cough, fever, and blanching skin rash. So have a very good look at it. It's something you see in the exams very often. Now, obviously, in the UK, is a fair child, the white child. But India, obviously, you will get the skin appearance will be different. But it's very common for UK exam. It's a UK exam, and this is something you see very common. So 11-month-old, A&E, one day history of fever, cough, and blanching skin rash. Now, very important. The skin appearance was consistent with which of the following? Go for it. I'll count till 10. Go for it, and I'll then go to the next one. If you're not committing, then it's your choice, really. 3, 4, 5, 6, 7, 8. Don't be, don't go by what others are doing. Make your own choice. Others might be getting it wrong. So think about it. Don't depend on others. So 6 people have answered. Okay. Now you might have multiple answers as well, but I guess which is the most likely. So you can have more than one answer. Okay. You can have more than one answer. Which of the following investigations would you do? ASO titer, rubella and measles serology, blood cultures, clotting studies, urine analysis. Okay. I guess, sorry, this is not come in a good way, but I think most probably are saying rubella and measles serology. Okay, that's what. So no ASO titer and all that. So most of the people are answering in rubella and measles serology. So let's see what's happening. So 1, 2, 4, and 5 was the first one, and 1, 2, 3 is the second. But let's go through this. Very straightforward answer. So it's a morbilliform rash. Now, morbilliform differential diagnosis. So basically, they want to see whether you know the differential diagnosis of a non-blanching morbilliform rash. So what is the differential diagnosis? Measles, rubella, streptococcal infection, Kawasaki's, toxic shock syndrome, roseola, which is a very mild illness, drug reaction, and non-specific viral. So this is what you need to know. That's all they're taking for really. Measles, rubella, streptococcal, Kawasaki's, toxic shock, roseola, drug reaction, non-specific viral. This is very need to know. And in most cases, in most instances, as was the case with this child, there is no evidence of shock or toxicity. The reassurance is all that is required. So basically, this child had a mild viral infection, probably a non-specific viral infection, and just mild fever. Light fever is not toxic. So reassurance is all that is required. So investigations are warranted when we do it, not in each and every case. If the child is unwell with high persistent fever, signs of shock, or severe mucosal involvement. So obviously severe mucosal is Kawasaki's, high fever. So then obviously you think of Kawasaki's again or similar conditions. That's where toxic shock syndrome, a lot of skin rash. Okay. So then you would do fluid blood count, CAB, CRP, blood cultures, ASO titer, yeah, viral serology. So viral serology is basically measles, rubella, and roseola. These are the things you want to rule out. Anti-staphylococcal license, clotting studies, biochemistry, liver function, and blood gases. So these are all we would do. Okay, I guess they're saying blood gases because they want to rule out if you've got Kawasaki's and things like that, or even if it's a drug reaction. So that's why liver function, because if it's a drug reaction, then liver function would be deranged. Also biochemistry. Okay, so that's that. I think that's it really, to be honest. Today, I think that's the end of it. I'll just stop share. So what's the time? 9:52, almost 10. Okay. Okay. So I hope that was useful with you got a variety of questions, nothing too deep, but I hope that you could get some idea of the different types of questions which are keeping on, commonly. I selected the questions from various places, from the topics I thought which keep coming in the exam. And obviously, these are some of the questions, but you need to develop it in more detail. You need to know it in and out, those topics in and out, because the questions will be obviously more difficult, might be more twisted, or the choices might be very close to each other. So, I hope this was helpful, really. So, any thoughts, anything, any messages? So, Deepa, thank you. Very useful and interactive. Thanks a lot. Any other thoughts from anyone before we all leave for dinner? Pooja,
So basically,
Ninja.
for AKP, paper one and paper two, I don't seem to find any difference in that. Is there any difference?
I think by now you should be knowing. Who's that speaking?
That's me, sir, Tanushree.
Anushri. Yeah, I think you're giving the exam by now. You must have seen. So I think there are some differences, obviously, because the big question is important. So AKP, I just want to see, because there are so many people here. I know the answer, obviously, but can anyone answer? Because Tanushri has asked an important question. She's just given part one. She's preparing for AKP. So what is the essential difference for AKP? Anyone? You can, you can, you can shout out or you can type or anything, because you should be knowing, but it is important, worth knowing, really. Any thoughts? What is the difference? See, the one I'm teaching is general. Okay, I'm not teaching in general just for specific for AKP, but I'm trying to cover more or less very broadly. Anyone? Any thoughts? You can type. Anyone? What is the main differences between AKP and FOP and TAS?
No, that I understand. Paper AKP one and AKP two. AKP is
I don't
basically
think AKP 1 and 2 are very different. I don't think it's designed in
okay.
that way. Yeah. But basically, one main thing is just remind me, Deepa, I think the cardiac catheterization, the blood gas, these are more, I think, in AKP. Am I right? So, the more
Yeah, sir.
tough, because the more hospital type questions, which are really tough. So, because broadly, if you look at it, part one, which is the FOP and TAS, is for previously it is to done by GPs who are preparing for DCH exam. So general practitioners. So they would have nothing to do with hospital practice. So if you look at it, that's how the part one FOP, foundation of practice and theory and science, they are, the questions are constipation, this immunization, which a GP would do in UK. All right, that sort of thing. Where autism, that sort of thing. Whereas if you look at this, the AKP paper, AKP is totally hospital oriented, more or less. That's why a lot of X-ray, a lot of EEG. Sorry, I did not get to cover EEGs. EEGs come up in the exam. You will get retina pictures of retinas. And sorry, I could not do the DMSA. I'll promise to do it next time, maybe. DMSA. So all are, like a hospital pediatrician, full form pediatrician would know. It is not something a GP would know. So obviously, cardiac catheterization values, blood gas. How would you manage what do you call they would give findings in what do you call a child who's ventilated, and they would give you a blood gas finding, and then they would say how would you what changes you will make on the ventilator. So these are what for a hospital doctor, pediatrician who's working in hospital. Yeah. So patterns of EEG you should know very well. Patterns of skin rashes, those come up in part one also, but still, the more serious skin rashes, which are like Staphylococcus aureus syndrome and differential type of blisters, which are very specific for pediatrics. Blisters keep coming up all the time in the exam, so you know very well about blisters. Okay, so these are what I would think. Broadly, it's a good question I think you asked, Jashi, because people need to have a broad idea how the exam is designed. Okay. And obviously statistics is more in part one, I think. Part two, not much, I think. If I may be wrong, just correct me. Okay. But I think you got a thing. The way I would ask you to prepare for the exam is go through list of retinas. Okay. What sort of retina pictures come up in the exam? Make a list. And then someone see the Telegram group is there. Why don't you post pictures? Be proactive. I keep posting pictures. No one else does. I don't know if you can do it. I think so. But basically, so or perianal rash. What sort of different types of perianal rash or eye? What are the different eye lesions which keep coming in? That's how I prepared. I remember. And then what are the skin rash in a child? The common. What are the different types of blisters which keep coming in the exam? Drug rash. What are the types? And even syndromes, it's not to be, the good thing about the Royal College exam is It's not that you have lots of you know it's not lots of uh, syndromes. There are only so many. I would say maximum there are 7, 8 syndromes, common syndromes which keep coming up in the exam again and again. So those you should be, and you should come in the picture. Then there are a lot of questions come about neurofibromatosis in different ways. Okay, and the syndromes also you saw like Bacterial. So there are typical syndromes which keep coming. Hemivertebrae, where do you get that? So Bacterial is okay. So you would have to go through that, and I would expect that you get used to by now what are the main types of pictures to expect. Because pictures, these are the ones where you can score really good marks. X-rays. So some of the X-rays will be NAI. So how would you diagnose or how would you miss? What are the different types which will come in the X-ray picture? Hmm. Any other thoughts? Anything before we
It
finish?
would be better if we could, do the classes system wise, so that we
For
also can
Tanushri,
prepare.
that for that you need to join our classes. Okay, this is just a free thing where we are just doing it just for a quick revision, just a quick picture of what we are doing. Yeah, but when you are, as I said, when you if you you're very right for actually doing the exam, and if you're really serious about the exam, you need to do it system wise, for which we are doing a course. Okay, that's where it's a full where people are doing system wise. Okay, this is just a thing where we are giving people an idea or new to the exam, just an idea what comes in the exam. But yes, for that, we are doing a course all the time. You were asking whether we do the course. We do a course. It's still running. It's a continuous course which we keep on going, and we'll give the details later on. And that's where it is done very much in detail, system wise. All right.
Just to interrupt you, sir, like those who join later, they might have missed some of the important
So I'll
topics. How
yeah
is
yeah we'll talk that in WhatsApp. Okay. No, it keeps on going. Don't worry about that because ours is a continuous thing and all the recordings are there anyway. So
so
whatever has been done is recorded. So it's a continuous subscription base. So 3 months and whatever is there, the earlier recordings are there. Another 3 months and they are all recycled. So the topics you won't miss anything. They keep recycling. So whatever have gone before was there. It is all recorded. Okay. So, and you've got plenty of recordings of most of the huge variety of systems. So that's not the concern. All right. So we have been doing this for about, I think, more than 7 years. At least from the COVID time, we started doing the recording. So you can imagine how many topics we have covered. And all are question answer based. Yeah. System wise, TAS, system wise. So renal system. Sorry, there are two ways it has been divided in the recordings as well. Obviously, before the FOP, we covered mostly FOP topics, which before the theory and science, we cover mostly theory and science. But as I said, even if you go only through the recordings, there's huge number. A lot of people, to be honest, people who have passed the exam before were getting stuck. They just went through the videos. When they we got the testimonials, they were getting stuck in the theory. They just went through a lot of the videos because it's so systematically designed, and we have done so many questions have been covered with good explanation and very systematically covered. So it's easier to do. Because I remember when I did it, I struggled because it's so vast and where to start, where to end, really. So you need to if you know exactly what are the main areas to cover and very systematically, if you do it, then you can save some time. Yeah, I hope that answers the question. All right. Okay. All right. Should we call it a day then? Okay.
yeah,
Are any other suggestions? Any other suggestions? Any other thoughts? And I hope if you're finding it useful, then we'll do it again, probably next week. But any suggestions, please let me know in the WhatsApp or you can message me. Okay. All right. So thanks everyone. Thanks for joining. And I
Thank you,
and
sir. Good
yeah,
night.
good night. And thanks to everyone for using what you call the Slido. So I'm very pleased that you use the Slido. And I guess you can see how useful it is when you use the Slido because you can see that you're committing. You can see how others are doing compared to yourself, and no one else knows. So no one else is knowing what you're answering. But for yourself, you can see where I am, where the most of the people are thinking, which are the questions which everyone is getting, which I am not getting, or which are the questions which I am getting right and others are not getting. And so it will help you to judge yourself in respect to the rest of the audience. So that is why Slido is very popular, and I've seen it used in various meetings and all over the place, and that's why you should be using it as well. Okay. So, okay then. Bye-bye and good night.
Thank you,
Thank
sir.
you so
Good
much.
Bye,
night.
Thanks
sir.
for joining,
Yeah.
everyone.
Good night.
Thanks a lot. Thanks for joining.